Cheers.
All right, so welcome everybody to the Heart Failure for T1 Cohort webinar. Thank you so much for everybody for joining. We know you have very busy days. It's very lovely to see some familiar faces. I'd like to introduce you all to the lovely educators. We have Senior Health and Wellbeing Coach Jiga here. We have Doctors Uzma Hay, Dr. Sandeep, and Dr. Danya Shuan. Take it away.
Yes, that's fine. So thank you everybody for joining us. I've got me, Danya Shoaib, Uzma Haq, Sandeep Singh, and we've got a lovely G here. Thank you everybody for joining us, and thank you Yasmina for pulling all of this together. I did say to Paul yesterday that we could not do this without Yasmina, but Yasmina's help and support. So any questions, please put them in the chat. We're more than happy to answer things as they go along. We also have a Q&A in the end. I think the most, and we will just take things, whatever it is, just put it in the chat. Just some housekeeping rules, please. Mute your mic, because just when people are talking, others, it's just good, so everybody can listen. Meeting is recorded, and there will be a feedback form in the end, which will help us develop for our T2 cohort. So please, please, please do that. That tells us what to do and how can we develop these webinars for the future as well, for the other cohorts. Thank you.
Thank you very much. I just wanted to add with the feedback form, if you do fill it in, you will get a certificate. All right, let's start.
Okay, brilliant. Hi everyone, I'm Sandeep. I'm one of the GP registrars working currently at Willow's Medical Practice under supervision of Dr. Shoaib. So this is a very nice topic for me. I have quite an interest in cardiology. So we'll start off by giving a bit of an overview introduction. And anytime you have any questions, please put it down through the chat, because we're monitoring that all the time, and we can actively answer them. There's 4 of us here, and we'll be distributing it between us to answer. So let's start with the first slide. So with heart failure, when we want to understand heart failure, the best thing to understand firstly is what the heart does, because that essentially will explain to us when the heart isn't working properly. The term heart failure can often sound very scary to patients, but essentially all it means is it's not delivering blood as much as it should do around the body. So if you were in the hypertension lecture, you probably would be a bit more familiar about these two terms, systole and diastole, and you will often see in blood pressure monitors. So systole is when the heart is actively pushing blood all around the body. Diastole is when the heart's taking a break and trying to fill up with all of that blood so that it can go to the lungs and get some oxygen. Now, what happens when it's not working? That's what defines heart failure. So if you just click on the presentation, you'll see that the images have swapped now. So this is a pictogram of what heart failure is. On the right side, you can see the problem of the heart failure here is that the heart's not pumping adequately enough. So all that blood is just resting there around the heart, and not a lot of it's going out to where it's needed around all our body cells. And the left side, you can see that the heart has got a smaller chamber, smaller volume. So not a lot of blood is being filled in for it to be pumped out. Only that small amount is being pumped out. So we've got 2 different types of heart failures that you can have. And the problem with that ultimately is that not enough blood goes to where it's supposed to be. And a lot of our living cells won't work as they normally should. And we tend to feel the symptoms of that, predominantly being tired and lots of other symptoms, which we'll go over. And one thing to keep in mind about this, the reason it's a very important topic is roughly we're looking at 1 million people in the UK are suffering from problems with heart failure. And every year we're getting roughly, I think, and my colleagues may correctly, between 150 to 200,000 new diagnoses of heart failure are happening quite often every year. So the next thing to know about is what actually is the inducing factors. Why are we getting all of this? So I'll hand over to Dr. Shoaib to tell you about the risk factors and what further induces propagation to heart failure. Next slide, please.
Thank you very much. So thank you, Sandeep, for giving a brief overview of what heart failure is. But what leads to heart failure? What is it that puts us at risk? So, apart from age and being genetically predisposed, there are most of the factors which my colleague G will be talking about, and the very, very important role I find of my social prescribers and my local pharmacists are modifiable. There's a smoking, controlling alcohol, diet. It's very, very important. And I mean, just by doing that, by just optimizing that, the unhealthy food, we can stop the progression or the development of the way your heart functions. Remember, the heart is the major powerhouse. It's what keeps us all going. So, and we'll realize it till the very end. We leave it. For some patients, and some, they don't have a choice because they were built that way. They had conditions, but for most of the people we see, they're modifiable. I mean, you can prevent diabetes, you can introduce lifestyle changes, and that could help. But lastly, and most importantly, I mean, chronic kidney disease. This is, again, something that could be helped with, something that can slow the progression of heart failure. And because what happens when you have chronic kidney disease, kidney disease, the heart. I mean, the harder the heart works, the more pressure it is on the kidney. And it causes the heart to be under stress, which leads the heart to overworking. And then it just becomes kind of tired. Next slide, please.
So, thank you. That was a brief on what risk factors, both modifiable and non-modifiable, causes and induces susceptibility to heart failure. And Dr. Shaw rightly mentioned chronic conditions, including CKD, can contribute to overburdening the heart with overload. So what does this mean? How do we understand this? And we understand this by the symptoms patients present us with. So the first one, and most commonly, is they're going to be short of breath, really, really tired. And Yasmin, if you click through, you'll see some more pictures appearing. And another one that you see commonly is a lot of fluid developing in the body of patients. They get overloaded. And then you also, Yasmin, if you just click along, it will just come up. And then these other things that happen is that patients will commonly complain that they're feeling very, very tired. And that's something that's not often picked up, that patients are feeling tired or they're feeling dizzy a lot of the time. We don't really know what's going on. A lot of the blood results are looking normal. We don't really know where we're going with this. They also complain that they can't sleep flat at all. And the moment they sleep flat, they're really struggling with their breath. They have to sit up and they need lots and lots of pillows. And one of the reasons we ask patients how many pillows you sleep with, it gives us a good indication of how much they can tolerate lying on the back and having all that fluid, all that blood coming back to the heart. Because if you've got too much blood coming back to your heart, but it's not working well enough to pump it out, it just floods your lungs. And that's one of the things that happen when you're lying down, and that's why you struggle with breathing. So the key things that we're looking here is the breathlessness, the fluid, tiredness, dizziness, and not being able to lie flat. So if you click, so this is essentially what we do when we're diagnosing. We get the history and then we do a couple of tests. And this is the flow chart that we use and tells us what to do and how to act on the results we get. But this is just a flow chart and it's really much simplified in 3 images. So these images that are coming up now is what will explain pretty much how we diagnose. So one thing is that we get a blood test. The second thing is that we get an X-ray imaging, which doesn't always need to happen, but it helps with people who are feeling short of breath. And the last and most definitive thing that gives us the ultimate diagnosis is the heart scan, the echocardiogram, and it tells us whether the heart is actually under heart failure. A lot of you might wonder, why do these processes and not just skip straight to doing the echocardiogram? The reason is both cost and benefit. If the blood markers show that there is no element of heart failure, and we have a certain chemical that we test for protein, sorry, it's called BNP. If that's really low, then it's pretty much diagnostic for saying you don't have heart failure. It's a very sensitive test. Now, if it's positive, then it's a likelihood of having heart failure, and that's when we actually do an echocardiogram, and then we go through the pathway and being like, this is quite reassuringly going to be heart failure, or and we want to find out the extent of it. And what part of the heart failure is it? Is it not filling well, or is it not pumping well? And what can we do? And if you go to the next slide, I'll hand this over to Dr. Shoaib to give you a brief on management.
Yes, thank you. Thank you. So this is slightly busy, but it's very, very good for us to have. Some of my colleagues that I work with, it's very good to it's the nice management. How is it diagnosed? My colleagues just spoken about, but how do we treat it? How do we control symptoms? We offer medication, diuretics, and then we look at, with the tests that were mentioned, is it preserved ejection fraction one again, or is it one with reduced one? Then we treat them accordingly. The most important thing here is, how do we control the symptoms? Again, how do we control the breathlessness? How do we control that people are able to actually sleep, basically? How can you add down? And this is just make an assessment. What do they need? See if your GP is there. We've got community heart failure nurses and things. But the most important role here is of my lovely, lovely team, who I really regard my pharmacists, my social prescribers, all of them, as to how do we deal with the whole person. Medication is the easy part, which we do, but it's their lives and everything, and how do we make sure we're doing the right thing for them. Next slide, please. So yeah, so this is just what the British Heart Foundation does. It just shows how it is. How do you get cardiac rehab at home? What do you do? Next, if you click, please. And this is just a picture saying how, if we play it, will it work?
It won't play. It's just
it won't play. It won't play. So just how, but you will get it. Is just how do you get some professional guidance on it, and it goes on a very, very easy way on how we should deal with it and how we should practice, but we should be able to see it. Next slide, please. So, and yep. So again, how do we manage symptoms? What do we do? What do we treat? And how do it will come up very, very important in our T2 cohort with pharmacists, and I've got my lovely pharmacists and others on the call here who would help explain how do we manage it. But the most important thing is, how do we help them understand the risks involved, and when is it the time for them to seek help? So actually creating awareness, making sure they're educated enough to come to that conclusion is, okay, my medications right now are not working. I'm continuously breathless. I can't sleep. Where do I get help? Next slide.
So
yeah, Dr.
That's a brief on management, and as Dr. Shoaib said, we want to make sure that we're controlling all the symptoms the best we can. The rehab program helps quite a lot in finding out how people can cope and manage their living day to day with heart failure and the extent they have it. And as you can see, heart failure management can get really complex with all of those flow charts and also with specialized care and when it reaches there. So the thing that we all need to know about, and all of us should actually be aware of this, is when do we worry about someone that's got heart failure? You'll see patients in your clinic with coding of heart failure. What do we do? So the times that we worry about it is there's going to be a stream of pictures that will appear. One of them is they're really, really exhausted, really short of breath, they're struggling to breathe, and sometimes you might hear some croaking noises when they're trying to breathe. The next picture, please. And one of the hallmark markers of heart failure getting really, really bad is when they got high blood pressure. Next. And the reason they get high blood pressure is it's just because the heart's struggling to pump all of that fluid out, and it's just getting accumulated all of the body. If everyone on the chat actually, this picture that we can see over here, if people can just type where they think that is in the body. Just a brief chat. A brief message on the chat. Anywhere you think it's in the belly. Do you think it's on the legs? Do you think it's on the belly? Do you think it's on the back?
Where is this? Where do you think this picture is?
So we got someone saying leg, someone saying belly button. It does definitely look like a belly button, doesn't it? Any other Once legs, okay, brilliant. I'm quite happy that a lot of people are saying legs because legs are pretty much the first sign of fluid accumulation in heart failure. But this is, funnily enough, actually the back because you can see just above it, you can see some elements of the spine coming out, but this is the lower back, and this is known as sacral edema. This is how far fluid can accumulate in the body. It can go all the way up your back. This is, however, the lower back, it can actually go all the way to the top of your back. Your whole body can be filled up with fluid because it's not effectively pumping it out. Now, this image on the right, it's a marker that not everyone would be familiar with, and it's quite a medical marker. It's a vein that's on your neck, and you can see here it's very clear and very engorged. And that's basically signifying that the heart is overworking, it's full of fluid, and it can't pump it out. And you'll notice that a lot of the time when people have got lots of fluid around the body, they'll also have this vein on the neck that's completely filled. Now, the ones on the left are the times where I would say they would need medical emergency management. If someone's really short of breath, their blood pressure's off the roof, the heart rate is really high, they need to be admitted to make sure all of that fluid comes out. Sometimes patients who have got really a lot of fluid around the body, there's only so much we can give them because if you've got fluid that's come up all the way up to the top of your body, there's no way that tablets will work well because it's not going to get absorbed because you've got so much fluid around your body, it's going to stop the absorption. It's going to be very slow till the medicine works. And these patients will end up needing to be in hospital for a while. And a lot of the time, if it's not well managed, they end up having heart devices or unfortunately, if they're not fitting the criteria for it, we do then have to think about keeping them for comfort care only. So one thing to highlight here, it's a chronic progressive management, just like we mentioned in our chronic kidney disease talk, that this is also another disease, another condition that progresses. And what we can do is give medication to reduce the progression, reduce the pressure on the heart, and help with symptom management. Next slide, please. So I'm going to hand over to Dr. Hack, and I hope that was a good introduction to what heart failure is. Any questions, continue, and we're going to be monitoring the chat. Thank you very much. And to Dr. Hack.
Hi, everybody. I'm Uzma. I'm a GP in Dagenham, and I'm at Surgical Gable Surgery. I'm also a PCNCD. So in my role, I do come across a lot of, non-clinical roles, and I'm also part of a bigger team where I am part of the education team. So we're training PAs, medical students, pharmacists, HCAs. I've been part of all of that. So just with that hat on, I thought, oh, how can I think about with heart failure, explain, because I value your input. Then when you try and quantify, like what is it, you would realize that it's more, I need your help than actually being a GP when it comes to heart failure. So I wanted to talk another dimension that adds to the complexity in heart failure, and it's the frailty. So it's like this picture is showing like somebody falls and, we just basically, why did they actually fall? But we're just more worried about their blood pressure or their numbers, it doesn't match up with what the patient's needs are. Please, can I have the next slide, please? So I thought my learning objectives from sort of this section that I'm presenting, hopefully with the background of the heart failure, what it is and how we manage it medically, which looks so complicated, but it isn't. It's when you do it, it's quite simple. It just looks very complicated. But it's just understanding how frailty settles in heart failure and how frailty would be affecting heart failure. So I've just put this picture up, and you can see where as your risk of crisis goes up, you can see that that's like sort of really small portion of people, but they're actually impacting on A&E a lot more, and they're heavily relying on urgent care. They'll have multiple admissions and very long admissions, and they'll just get more and more frail. Next slide, please. So frailty is when people lose their reserve in their body to bounce back, so their resilience. So like if somebody who doesn't have frailty catches a chest infection, they're fine, they bounce back, maybe a week, 2 weeks, but they still carry on functioning. They might still be going to work, looking after their kids, but as people start to get frail, and it's not just an age thing, if you're like a young person, they'll catch a chest infection and then they'll be falling about they'll be, unable to function at all. They'll actually be, somebody will need to look after them. So those are things that happens that you could say this person's getting frail or is frail. It is a long-term condition now, and things that would actually predict whether somebody has frailty or not is like how much help are they needing for their activities of daily living, and it will help us predict their future crisis risk. They'll be at risk of hospitalization, so admissions, and admission is quite a dangerous thing for this group of people. They catch infections, they get clots, they decompromise even more, and then they get even worse. And it reduces their life expectancy as well. They'll present to you guys with falls. So somebody would have asked, can you please refer them to the fall service or social prescriber because they have reduced mobility, they want a wheelchair. They'll be getting more confused. Delirium comes in, so there'll be the cognition declines. Heart failure is a very strong risk factor for dementia, and the more frail they are, the dementia is worse. And it happens in any age group, this frailty thing. And we've got younger people with heart failure in Dagenham and quite a lot of Northeast London. So they have loss of fitness and they're not able to adapt socially with frailty. So we're going to talk a bit more about this. Can I have the next slide, please? So like I said, heart failure, having it increases a person's risk of having dementia. So they'll have other comorbidities existing. I wonder if you've come across them and seen that they also have COPD, which is the bronchitis. It looks like asthma, but it's a slightly different one. This one is not reversible. Asthma is reversible. They get sort of heart disease. Obviously, heart disease would have been the beginning of it, and then they've ended up having heart failure. They can have atrial fibrillation, which is when the heart doesn't beat regularly, and that is associated with stroke. They have CKD, so we've also got CKD webinar in this series. So I think the first one's already happened. So it's all linked. When you attend all of these webinars, it will make sense and all kind of join up together. I thought this was a really good picture to show how all these different things will be impacting a person with heart failure, and then how it gives them frailty, and also if there's already frailty there, it will just be worse. So you can help with all of these things in terms of linking them up with the community for obesity, for exercise, for giving up smoking, because all these things really help improve the quality and reduce the frailty. So frailty, some people think is not reversible, but you can impact it, and it might be a bit more kind of livable with. So you can reduce the impact of frailty. Some people confuse frailty with vulnerability. Vulnerability obviously is reversible. You can get rid of it, but frailty will probably still exist in some form, and they'll be at higher risk of becoming more frail. Next slide, please. So I think recognizing frailty is where you can help, where you can see people are getting worse, they're deteriorating rapidly. The GP might have asked you guys to please help us with this because they can't get out of the house, they're housebound now, they need help with work at home. You can have this discussion with the GP that, if they haven't noticed it, that, this person's getting frail, and they'll be at risk of harm from actually at risk of harm from the medication they're actually getting. So they'll be falling out about a lot more. So their mobility will go down. They'll become socially isolated, and they get depressed. And that is like really sad, and it affects how they respond to treatment. So personalizing their care is so important in this. I think it plays a bigger role than actually medication and these other medical interventions we do. And sometimes these interventions can actually have a negative impact on them. So people, at the moment, because personalization is just like about 5 minutes old, if you compare to medical management, we've only been talking about it for the last 5 to 10 years. So people don't realize how important this is. And once they actually meet a social prescriber or they meet a care coordinator and health and well-being coach, they realize how their life is completely different, because you also need to work on their mindset. They need coaching, how to cope with this. So heart failure, we can't get rid of it now. Once people have had it, it's not curable. It's a palliative condition, and it's a progressive condition. And actually, in the last 12, I mean, once it gets severe, that their life expectancy is less than 6 months. It's worse than cancer. So yeah, and it's really like, I didn't realize this. Is only when somebody said this to me that I found my pulmonary hypertension patients, they're gone within 3 to 4 months. So they get it diagnosed because they had an admission in hospital, and that's it. Then they're gone. So it's we have to focus on their quality of life. Now, please have the next slide. So it's recognition of this end of life is very important in this. And somebody who's had a who's severely frail and has had a hospital admission, you know, they're 50% likely to die in the next 12 months. So it's very, very yeah. So anybody with any of these things where they're dependent on other people, or their frailty score is 7 or 8, I'm talking about the Rockwood frailty score. It's like a picture diagram where you can just tell if somebody walks with a stick, it's a score this, it's a score that. Can I have the next slide? Yeah, please. So I just wanted to show that we have shared the guidelines with you how to treat them, but actually, for some of these patients, if we go by the guideline-based medicines, actually have poorer outcomes. So in this gray box where I've got like these 4 areas, so the ones that benefit the most with the guideline-based ones are the well-controlled types who have just one long-term condition. Once frailty starts to settle in, and depends on where they are on this line, if they're on the 4th line, where they have heart failure with severe frailty, they're the ones who actually are adversely affected by following the guideline-based medicine. So even if it says give them more and more furosemide, give them more and more, or let's put a pacemaker in them and let's do all these interventions, it actually, you know, so the whole person consideration, right? What is more important for them now? And it might be more important for them to not be socially isolated because they can't get out of the house. And that's where I think community, voluntary care sector, social prescribing can really, really help. Can I have the next one? I think it's just got 1 or 2 slides left. So I thought I'll put this down. It's like a coalition of personalizedcare.org. You can sign up to it so you can get the newsletters, and it might be helpful for people who are in the personalized care roles, such as, you know, social prescribers, care coordinators, and your health and well-being coach. And it helps to kind of work with people to develop their care plans and how you can actually make an impact and help them. Now the next slide, I think that's the last one. I wanted to test. I don't know if we have time. Do we have time? Do you think we've got time for a few minutes? It's only one question.
It's 2:30.
Okay, I want to give G, because I really want G to. G is this magic pill we've got at the moment.
No, G is lovely, but I think you have time, Uzma. Please finish.
So this question is, so what is frailty and its relevance in chronic disease management, such as heart failure? Which one, so if you think about heart failure and frailty, which of these 3 do you think is correct? You have to choose 3 which you think is correct. Is it A, frailty is always present with aging and seen in other people, seen older people? Or the risk of developing frailty may considerably increase with other coexisting progressive long-term conditions like heart failure? Or do you think the next statement is correct? Frailty creates its own unique set of physiological responses in the body that often differ from those who do not have it. Or it's D, or it's E. So these are just statements regarding frailty and chronic and heart failure.
Use the chat to answer.
Yeah, you can put it in the chat. Yeah, thanks, Andy. You have to choose 3, Mary. You can choose 3. Yeah, B, C, E. Yes, I think B, C, E is the correct answer. So well done, who's got this. Because frailty, remember, it's not just for old people or just seen as people get older. It could be young people. and old people, not all of them are frail. So brilliant. I'll hand over to G. Thank you.
So much, Uzma, and thank you, G, for actually coming in as the specialist in all of this. Thank you.
Next slide, please. Thanks, Uzma. Okay, so let's look at our roles. Firstly, I want to apologise. I have got a cold, so if I switch the mic off, I'm coughing, and then I'll be back on again. I'm the Senior Health and Wellbeing Coach and also supporting the clinicians with developing education for the personalised care roles. I'd like to talk about a few examples of personalised care roles in the management of proactive and early prevention of heart disease. Next slide, please. So we know that cardiovascular disease is probably the world's #1 killer. We've already looked at the risk factors for CVD, and in the hypertension webinar, I touched on Q-risk as a risk assessment tool to estimate a patient's 10-year risk of developing CVD. And I've put a link on this slide for those who are interested. What does this actually do? It looks at all of the risk factors associated with heart disease. So things like smoking, diabetes, AF, things that have already been mentioned. It would be really interesting to know if you could all share in the chat whether you are familiar with this tool, if you've worked with it, or if you're involved in any work streams related to heart disease, or any projects that you may be on. It would be really nice for us to understand where, you know, everyone, what interests people have and where they're actually working. Next slide, please. So the NICE recommendation suggests that all people who have CVD risk assessment should be given lifestyle advice. And obviously that's where our expertise sits really well. And this is advice about smoking cessation, weight loss, eating a healthy diet, keeping alcohol consumption low, being physically active, and for pharmacists or the clinical side to look at statin treatment. Next slide, please. I'm just sharing some resources which look at protocols and pathways. This was a project that I was involved with whilst working with Havering North PCN, and the UCL Partners Framework have some great resources available for anyone interested in getting involved with work streams to do with CVD or risk factors associated with CVD. Here on the right, you'll see that the work stream I was involved with was CVD prevention, and really the workforce that got involved with this work stream was in primary prevention. That was dedicated health coaches, care coordinators, social prescribers and mental health practitioners, because we all have a vital role to play. Let's get beneath the disease. Let's get back to basics, take it back to its bare bones. What's really going on in the lives or the lifestyles of these individuals. And obviously the secondary prevention is clinical pharmacy led, and that's with medicine use reviews. I've added a link to the UCL Partners resources. I highly recommend that you take a look at that. Next slide, please. So the role of, I think we all know now what our roles are, and I really want to get to the heart of the matter. And really, what is this about? This is about changing our conversations from what is the matter with you, which is what most clinicians will ask, to what matters to you. We know that our conversations are not disease specific. So really, it really doesn't matter what a patient presents with. We want to support and help them with the rest of the lifestyle issues that are going on. If you press the slide again, please. And again, thank you. So social prescribers will look at the wider determinants of health, such as housing, benefits, social isolation, career support, community connection, which is vital when it comes to heart connections. And really, if you look at things like sadness, unhappiness, why people are depressed, is because they lack a connection. They've lost connection with those streams in life that brought them joy, that brought them happiness. Care coordinators are brilliant at supporting and coordinating care or navigating care for patients with such complex needs, especially with learning disabilities or those with multiple long-term conditions who need a bit of care navigations, and especially with those with frailty, as Uzma has just alluded to. And health and wellbeing coaches, well, I suppose we're experts in lifestyle and behavior change. So how can we break these habitual patterns that we are unconsciously involved with and don't realize how it's impacting our life negatively? Next slide, please. So I'm just going to have a deeper dive on the health coaching side. I was toying with the idea of sharing case studies, but then last night I had a bit of a brainstorm and decided to take this a different route. But we're all familiar with prevention of heart failure. There's so much evidence out there online. We've got support systems that are in place in community about lifestyle factors, as well as the medical conditions such as treating high blood pressure, controlling diabetes, and cholesterol levels. But I really want to take this back to the bones. Next slide, please. I remember in the first 6 months of joining the NHS in this role as a health and wellbeing coach, some of the outcomes that I presented. And within the first 4 months, there were about 265 referrals, 76% of those were discharged, and there were about 46 patients on the waiting list. And this was really at the height of lockdown and COVID. So lockdown cases, there were about 60% of cases which were to do with weight, anxiety, sleep issues, depression, isolation, low mood. I think we've all experienced it. So I'm just painting that picture. Long COVID was strife, and long-term conditions were being signposted towards the lifestyle clinics, the health and wellbeing coaches. Some of the non-clinical interventions that were used were diet, lifestyle advice, activity, because obviously there was a lot of sedentary, people were locked indoors, and isolation, behavioral patterns, so motivational interviewing, and there were some that were referred to social prescribers, and about 50% of them also required mental health interventions. But some of the outcomes showed that there was an improved score, perceived stress scale score, after 4 to 6 sessions. Some of the patients, their pre-diabetes improved within 12 weeks. Within 3 months, we saw weight reduction. People felt motivated. There was improved mood, and there were improved energy levels. And this was all non-clinical. So what was actually going on? 9 out of 10 patients actually showed marked improvements, and that's after 6 lots of 60-minute health and wellbeing coaching sessions over 12 weeks. Now, these I'm sharing my personal experience of these cases. Next slide, please. And these are some of the feedback that we got from patients. So this is what really mattered to the heart, getting to the heart of the matter. Previous counselling over the phone has been a matter of fact and impersonal, whereas talking to a health and wellbeing coach has given me the confidence to talk from the heart and resulted in me finding alternative methods to improve my wellbeing rather than taking a tablet that plasters the problem. So this touches on the point I think that Uzma raised, or was it Sandeep, that sometimes we're taking medication, but there's no improvement. So what else is sitting beneath the clinical manifestation, beneath the symptoms? Someone achieved a greater awareness of triggers, was skeptical about health coaching, but felt much able to manage stress and anxiety, sleep better, and they'd encourage more people to use the service. After the first session, I noticed calmness, Practicing the techniques has helped my anxiety. I'm calmer. I enjoy visiting G, and why not? I've been able to share information with friends and family, encouraging people to take similar healthy steps. So there's a domino effect happening now. First time I've not felt dismissed. It's not so much about feeling dismissed. It's the lack of time that clinicians have. If clinicians had an hour to spend with a patient, they would be magic. They would be magicians for certain, because patients want to talk. They want to be heard. And that's what we're privileged with, time. Next slide, please. Okay, so where are we going with this? When I sat back and looked at all of the cases that are presented or referred to personalised care roles, and we start really stripping back the symptoms, this is one thing that I show to patients. I show them this piece of paper with all of the psychological signs, emotional signs, physical signs, and behavioural signs. And I ask them how many of these signs and symptoms they present with or have presented with over the last 3 months. I'm going to ask you to do the same. So if you were to look through these lists, how many of those would you be able to tick off right now? So inability to concentrate, make simple decisions, forgetfulness, easily distracted, worrying, negative thinking, a little bit of anxiety. Yeah, thanks, Raquel, most. Emotionally tearful. How many of us are tearful and irritable right now? Defensive, feeling out of control, having a lack of motivation, angry. I'm finding that a lot of people are angry at the moment. Lack of confidence. Physical signs, aches and pains. Where is the tension sitting in your body right now? Around the neck, shoulders, the wrists, the lower back. Frequent colds and infections. I'm raising my hand. I'm down with a cold. I've literally gone on holiday and I'm down and out. So I know the stress levels are mounting up in this body. Allergies, rashes, constipation, weight loss or weight gain, tiredness, and some of the behavioral sign, increased reliance on alcohol. So how many of you turn to wine every night to relax? How many of you are smoking or caffeine binges? We don't realize we're having 6 to 9 cups of tea or coffee a day. So you get the picture, right? Next slide, please. Now, these are all signs of stress. And the general picture that people would present with are in these, are written here. It will also present with skipping breakfast. So they don't have time for breakfast. They're running on empty. They have energy dips between 11 a.m. and 3 p.m. and they're reaching out for the caffeine or the sugar. They're tired in the afternoon, but wide awake at night and able to shut down. So how many of us can relate to this? Next slide, please. Now, some of the common habitual coping strategies you'll see here: smoking, caffeine, drinking, chocolate. Next slide. But these are all stimulants. So how can they actually help us? Next slide, please. Now, I just want to give a little background on the general adaptation syndrome. How many of you are aware of this knowledge, the general adaptation syndrome? It was identified by Hans Sale. I've put all of the information here. Really, it's the body's resistance to stress. What is the pattern that the body presents with? So it's recognizing the impact of stress on our physiology and the triggers. Now, stress has a predictable pattern on the body. So whether it's a small stress or a big stressor, the body is going to respond in exactly the same way, which means we can do something about it, right? It's predictable. Next slide, please. And the predictable pattern is the alarm, resistance, and exhaustion phase. Now, what does this mean? I apologize if I'm speaking to the already converted and knowledgeable, but it's just a reminder. It's to remind us where we're at right now. Some of the common symptoms that present at the alarm phase is heart rate, blood pressure, muscle tension, our digestive function shuts down. So we have loss of appetite, increased energy, and tension. We feel invincible. That's because we're in survival mode. Our libido falls. We're not interested in making babies, and our thoughts are scattered. So we become clumsy, agitated, tearful, and also anxious. Now, this is where lifestyle interventions come in. And this is where I've seen between 6 to 12 weeks of lifestyle interventions to get people back to balance, restore the equilibrium. It takes around 3 months, and it's all about rest and repair. So it's doable at the alarm phase. So when we're looking at preventing heart disease, we really want to nip it in the bud at the alarm phase. So understand your triggers and take a step back. At the resistance phase, this is the shock phase. So this is when people come in when they're not sleeping well, they have inflammatory conditions, poor concentration. A lot of people stay in this phase for a lifetime, while others will deteriorate. So high blood pressure, cholesterol, prediabetes, asthma, allergies. Now, this is where early prevention, lifestyle intervention is really impactful and can take up to a year and a half to help them restore the equilibrium, along with clinical intervention as well. And then we have the exhaustion phase, and this is really when the adrenals are depleted, and this is where we get kidney issues, chronic disease manifestation. And really our job then is to help people accept where they are and adapt to their chronic condition and their long-term condition, and provide them with that extra support and help. I hope you've enjoyed that slide. I enjoyed putting it together. Next slide, please.
Just to let you know, everybody, we've got 10 minutes left. Shall we continue on and get everyone to please put your questions in the chat box, everybody, if you can. Thank you so much.
Thanks. Next slide, please. I'll whiz through the next. Just wanted to focus on Christmas. It is one of the most stressful times of the year, and if you're not feeling it, you will soon. And there's, I noticed there's a 25% increase in mental health conditions within the 18 to 25s over the past, since 2022, 2023. And these are some of the factors why people are stressed, right? So just be mindful about the season we're in and perhaps take a step back. Next slide, please. So how do we restore equilibrium within? Unplug. What does that mean? Pause, take a step back and just say, and stop. Hydrate. That means drink more water, not more wine, not more alcohol, but more water. Next slide, please. The awareness of breath. So one of the first things that will go out of keel, that will take a back seat, or which will change when we're stressed, is our breathing. So the moment we have awareness of our breath, the moment we slow down, just step outside, stamp your feet like the terrible twos do, sing or laugh, this will bring us back to our breath. So these are my top 3 tips, which is the awareness of breath. One of the things that I taught before in the hypertension webinar was the bellows breath, which is where we literally raise our arms up above our head in an in-breath and draw the elbows down to our lungs and shout on an exhale. And if we repeat that 3 or 4 times, it actually resets the body and the mind and brings us back to our equilibrium. So it's very simple. Next slide, please.
Only said well, like 1K. Oh, no.
These are some resources that I'm putting down that I've just shared with regards to the healing power of breath, which you're quite welcome to have a look at. Next slide, please. And movement. So here I've put seated twists. So it doesn't matter where we are. The moment we feel the tension, we can do some seated twists. We can stretch the body, and we can also do a body scan. So I've just put a little top tip about how to do a body scan, meditation, using the breath, getting comfortable, closing your eyes or focusing on something, and just bringing your awareness back to the body, because our mind is generally overworked at that time. So come back to the body. Next slide, please. And really be kind to yourself, especially during this festive season. There's a link to the Mental Health UK, which has got some excellent advice on what to do to bring us back to center, back to our equilibrium. Next slide, last slide. Just one question. What is the key ingredient for a healthy heart? I think everyone saw that.
I'm so sorry.
Okay, it's happiness. So we don't need a pill, it's actually happiness. And one of the next slide, one of the easiest thing to do, there's a great pressure point just between our breastbone and underneath the armpit. So a self hug. So if you just wrap your hands and hug yourself, do a self hug, you're actually pressing into the pressure point of the heart, which really rejuvenates, reduces anxiety and rejuvenates a happy heart. So that's my contribution for this webinar. Thank you.
Thank you. I think my cat really enjoyed you. She's like, as soon as you started talking, she was like, she loves the laptop anyways, but it was like she heard your voice and she wouldn't let go. So I was
I did
thinking
catch a glimpse.
happiness is having a cat.
Happiness is definitely having cat. Animals are great at reducing stress. Yeah.
Thank you so much all. That was wonderful. I saw that someone had asked if these slides will be available, and what we do actually is to upload this particular recording onto the website. If you wish to get the link to the recording, which is on our website, please do contact me. I think you've all been receiving emails from me. My name is Yasmina. Could I ask 30 seconds of your time just to answer the multiple choice questions? Some of you have done it. For each and every one, you'll be getting a certificate. I will put it in the chat right now.
It's literally 30 seconds. I've actually tried it myself. Less than 30 seconds. It's yes and no, and that's about it. Yeah, and you'll receive a certificate after you've done it. So please, please do it. And Yasmina, you've put the link here.
Yes, I have. Right here.
Does anyone have any questions at all they want to ask?
Anything G, Dr. Singh, Dr. Hack, or myself can talk to you about or help you with?
Yeah, it's very well informed, I think.
I
Yeah,
think
we've
we
stunned them.
educated the T1.
We've stunned them into silence.
That's the best way you can put it, stunned into silence.
I mean, I think it's just an amazing work that everyone's doing with personalized care, and I think we should carry on, because social isolation is a big killer. And for all our frail, you know, most of them are older adults, because I do frailty for BHR, so 3 boroughs, and a clinical lead for that, and it's I didn't know how social isolation is like a big killer for these people.
Yeah.
So it's just how you can get them back connected to the community, link them with this local council, with all the initiatives that they can access. I think Alexa is quite big these days with all of these things, councils like getting Alexa for everything these days. But it's just amazing how much stuff is out there that you can help with, get them exercising more, yoga, tai chi, breathing exercises, you know, pulmonary rehab. I think that all really helps and makes a difference.
It does. And some of them go to chair yoga classes, and it's just it's just there, it's just linking them in with the community. But yeah.
I think also, just one last point, as you know, clinicians, healthcare professionals ourselves, I think it's really important for us to take a step back. We don't realize how much we take on board when we're seeing patients. So really have some self-reflective time for yourself. Self-care is essential. Self-being.
That's a good point, actually. Dr. Sherb, can I get a day off?
Yeah, see, that's how my world works. Yeah, get your self-care study leave day in lieu. What do you think, Dr. Huck?
Yeah, it's definitely on my appraisal PDP, health and well-being.
You know, everything.
I'm going to the spa. I've booked a spa with my friends.
Are you going to take me and G and Yasmina with us, you know?
It actually
Why not? Yasmina, you have to get it.
Oh, I'd love that.
Any questions, anybody, for us? We've educated everybody on heart failure and how to self-manage. We all need to give ourselves a pat on the back. But anything that you would like improvement on, please put on the feedback form so this dream team can put together a good way for a good way forward for the cohort 2 that we will be doing.
Yeah, please, because I know an hour is not enough for to cover all these, like you could see how much stuff there was in G's presentation. You know, it's very, yeah, I think we need more time.
If anyone's interested in a stress management session, if you put your interest down, then I will prepare one, because just to do that stress management